Well, good afternoon and a warm welcome on a chilly day to all. Today, we're going to be looking at a really interesting subject, which is interconnected innovation, healthcare learnings from animals and the environment. My name is Leigh Mair. I'm the Innovation Manager for North Scotland and the Islands, and I'm joined by my colleague, Robert Ray, who is Head of Innovation. We're delighted to be welcoming two fantastic speakers today who are based in the Highlands. We're going to be exploring a really fascinating topic around One Health, which incorporates animal, environmental, earth health to human health and well-being and the potential for innovation around that. In terms of housekeeping, this session is being recorded and it will last 45 minutes. So we're due to finish up at 12:45. Our speakers will do their presentations, and if you want to ask a question, and please do ask a question, just pop that in the chat box and someone from InnoScot Health will be collating these and we will ask them at the end of both talks, if that's okay. So, a bit of a background to this session today. Why look at parallels? Well, we're all aware of Scottish Government's aim to transition to net zero economy. It's something that we're aware of privately in our professional lives also. There's also a push to reduce emissions of CO2 and other greenhouse gases. And actually just doing a bit of research this morning, the Health Service contributes 4 to 5% of total UK carbon emissions. Which is quite a huge amount when you think about it. And also we're going to be Adam's going to be exploring improving land management and preventing new zoonosis. We know with COVID how important these novel zoonotic disease can impact us all. So really important to look at these in a bit more detail. So I'm delighted to be introducing Dr. Adam Giangreco. He is the SRUC Head of Business Development for Rural and Veterinary Innovation Centre, the RAVIC in Inverness. Adam's background spans both academia and industry, having run an independent research group at UCL, followed by time with the Technology Partnership, a life science and tech consultancy based in Cambridge. More recently, Adam served as Director of Health and Life Science Innovation for the University of Highlands and Islands. Okay, over to you, Adam, if you can share your screen. Stop. Oh, you're on mute.
Sorry about that. It's a rookie mistake. Hopefully people can see the slides all right now. So yeah, thanks very much to Leah and Robert for inviting me to present this today. So I'm coming to you from Inverness, circled there as the gold star. The gold stars on the map are SRUC campuses, so we're right across Scotland, and we're very prevalent across all of Scotland. If the red markers are our consulting offices for our commercial arm, and really that reflects in that Venn diagram on the right-hand side there that SRUC, although we're an enterprise university, really we work at the interface of government, commercial side and society with this overall aim of knowledge creation as well as creation of skills and jobs to try and deliver innovation enterprise right across the rural economy in Scotland. If you've heard of SRUC, you might be thinking, why is he here today? And thinking, well, they just do things with cows and sheep and maybe fish if you're really into it. And that's true. We work with about 8,000 farm businesses across Scotland on the commercial side. And I suppose the bread and butter of our work does involve that. But really in Inverness, what we're launching in the Rural and Veterinary Innovation Centre, which is part of our School of Veterinary Medicine, is much broader than that. And I hope to convince you about why that's important to think about things in that broad and holistic way over the next few minutes. And our mission locally is to address globally important human and animal health, agriculture and aquaculture needs, and really position SRUC not just in that rural and livestock and crop space, but as leader in planetary health innovation. And that's particularly relevant in human health for a number of reasons. One, which is maybe the most obvious one, is the zoonotic disease space. So 61%, well over half of human diseases, infectious diseases, actually originate from animals. So I've put a picture of chickens up because people probably think of bird flu as an obvious one. But the lists go on, and any number of different types of animal species and different types of conditions often originate from animals. And in addition to that, and very closely related, foodborne pathogens, so from fish or from meat or from chicken, cause more than 16,000 hospitalizations per year in the UK. So in addition to that zoonotic, looking at pathogens either from plants or from animals is very much in scope for SRUC. And then even closer onto the human side itself, farming, as many of you know, particularly if you live in rural communities where farming and agriculture dominate the economy, is really physically and mentally demanding. And on the mental health side in particular, this has been in the press a lot lately. 47% of rural workers, that's farmers and veterinary as well, are reporting regular anxiety. And really worryingly, 19% of people that were interviewed from those agricultural sector and rural sector jobs report knowing someone who's actually attempted suicide. So quite a significant and growing challenge there on the mental health side as well as the physical. Decided to have an interesting animation there. And then on the sort of more global stage, we're talking about planetary health. SRUC and RAVIC is also very active in the global public health space. And so looking at access to clean water and sanitation, healthy and quality food, and vaccines and medicines in rural communities remains an ongoing global health challenge. And the picture there is just from a regular screening that some of SRC does in partnership with aid agencies in Africa, in particular, looking at parasitic worm infection is something we're active in right now. So within those four key themes in the green boxes there, you know, veterinary surveillance, food and livestock pathogens, human rural health and well-being, and those global health challenges, how do we do that? And what we do in RAVIC is probably very similar to what many of you do in the NHS and in human health sectors. So we take a very holistic approach with multidisciplinary teams. And in the bubbles below there, the veterinarians and data scientists and modelers, and on the commercial side, farm consultants, right on through to social science and molecular and microbiology, we bring those different groups of people together as needed for the individual projects and to answer specific questions. And we feel very strongly that it's that holistic, multidisciplinary approach that gets a better, more sustainable solution out, which is either technology or service or what have you, that helps both the workers as well as the wider society and the planet from an environmental perspective. And I'm just going to tell you a short story about one example of where we've taken that holistic approach that's been quite successful. This one's thankfully not yet a zoonotic. It's not yet shown evidence of jumping to humans, but it's a disease in cattle called bovine viral diarrhea. BVD, although the drawing of it looks a little bit like a COVID thing, if you've sort of imagining that, it's not. It's what's called a pestivirus. So the closest human equivalent is German measles, actually. The way BVD spreads is surprisingly very similar to COVID. So it's a respiratory illness, so they can breathe on one another, and that spreads the illness. And also, thankfully, slightly different than humans, it's often transmitted from a cow that's asymptomatic but infected, being sold at market. And so a farmer will unknowingly buy the disease into their herd after they've gone to auction market, which locally is Dingwall for us, for anyone in the Highlands. What the disease does has an impact on poor growth, and so the cow is producing less milk, or it's smaller, so it produces less beef. Obviously, there's negative environmental impacts, so they're eating and drinking, but it's not producing what you want from a cow, so that's bad from a carbon footprint. The infection can infect new calves that are in utero and result in spontaneous terminations within those cows. Very sick cows can end up killing them. And perhaps the worst issue of BVD is that a persistently infected but recovered animal can remain as a persistent infector and cause the BVD to spread throughout the entire herd. So you're talking hundreds of cows infected from a single PI cow, as they're referred to. And the prevalence back in the early 2000s up to around 2010, this is from 2013, the map on the right-hand side, was up to about 40% in Scotland. So it's not a rare disease at all. It's quite prevalent. That's 40% of herds rather than 40% of cows. So very, very common. And as a result of that, Scottish government launched an eradication scheme in 2010, which, and this will sound very much like COVID, involved a series of different steps. So routine testing, either from point of care tests like a lateral flow or PCR testing, vaccination for BVD as a requirement, movement restrictions, so you have to screen negative before you're allowed to bring a cow to mart, similar to the airline restrictions that were in COVID. Biosecurity, so social distancing, you had to put 3 meters of fencing between new cows onto your farm and your old cows. And thankfully one that wasn't in COVID, compulsory culling for any cattle that were tested positive. So what did we do with that holistic multidisciplinary team that we had below? Well, we answered a few key questions for the government on this and for the farmers. So where's the BVD coming from and how is it changing? How much testing might you need? What might farmers think of that scheme? And how to communicate those benefits best to the wider public and to those farm workers. So just in the last couple of minutes, I'll cover off how that came through in this project and as an exemplar of how it works more generally within SRUC. So how much testing is needed just to make quite an extensive mathematics story accessible and quite a lot shorter. What we did was a mathematical model looking at a prediction of how confident could people be in their cattle being BVD free versus the number of tests. We found actually it's difficult to have high confidence and high certainty of that BVD free status unless you had quite a large herd, so 300 negative tests in one go. So that would be quite challenging. Most farms in Scotland are relatively small and may not have those numbers of cattle. So that says routine and frequent testing is the solution there that we were able to help provide to the government. And that is what's done today. In terms of where is BVD coming from and how does it change over time, we brought in our molecular and microbiology teams and brought those in with veterinarians and data scientists, and we're able to build phylogenetic maps of what BVD looks like in the different substrains and how those have changed over time. That's helped inform new types of vaccination. It helped inform particulars on movement restrictions. As you can see on the map on the right, we're able to tie that phylogeny to how the disease was moving from different parts of the UK up into Scotland to impose specific movement restrictions when new strains were detected in other areas, and also helped inform that surveillance strategy of when and how much sequencing needed to be done in particular. This one's perhaps really important. So it's all well and good having great science, but if no one buys in and if no one's compliant or adherent to it, much like a medicine, the medicine only works if people take it. So here we were working with our social science team and farm consultants to work directly with those producers of those cows, either dairy or beef. And what we found at the start was actually a very negative experience and a very negative feedback around policing sort of approach. People felt that they were under a lot of stress or they're harassed, or it was a really horrible experience. And what we were able to do from that information was to shift that narrative and to make it much more that this isn't the farmer's fault. It's much more of a helping hand approach around more practical advice and support for a challenge that they've got as much as that the government's trying to address with BVD. So care around the language and building relationships rather than policing and saying, you must call now, you've got negative, you've got a herd that's positive, for example. So very much informing how it's done. And then finally, as part of that, how did we go about communicating those benefits to make them meaningful and actionable to those farms? And this was, bringing in what would be considered on the human side a health economist. Here it's just an economist, I suppose, or an animal economist, really articulating what the impact is of even a single persistently infected cow within your herd. And we were able to quantify that out from a dollars or pounds perspective here. So it's up to 55 pounds per cow per year. So that if you've got a herd of 100 cows, that's quite significant. It's over 5,000 pounds a year of lost revenue just from having one persistently infected one coming through and infecting your herd. In addition to that, from a health and welfare perspective, we're able to show that just over 5% of calves would terminate if there was an infection running through your herd. And you'd also have a lost productivity in terms of milk yield if it was a dairy herd. So we were able to say then it's cheaper and it's better for the cow and it's better for the environment, it's better for your farm to vaccinate and screen and comply than to risk infection. So very much articulating the risks and the positives there. And overall, I said this scheme started in 2010 from the Scottish Government. The map on the left was the one I showed at the start from 2013, where there's still very high prevalence, particularly down in the southwest. The middle map is January 2018, so you can see things have gotten much better. Prevalence rates were down, and this is still ongoing now. So we're currently in phase 5 of the eradication scheme. And as of this month, amazingly, we've gone from, and I said in 2010 it was a prevalence of 40% of farms. We're now down to 5, and that's not 5%, that's 5 out of over 8,000 farms, so 0.06%. Interestingly, you can now track and see where those are, so you can make your decisions as a farmer whether you want to interact with those individual farms that remain. And this work was so significant, it was very recently awarded one of the Queen's Anniversary Prizes. It's SRUC for our work in vet services, taking this holistic approach. So really good recognition of a national level impact. And it's been so successful. We've been approached and the Scottish Government's been approached by other countries and other territories as to how to help eradicate this in other areas as well. Just to end and say thanks very much. This was SRUC-led work, but very much as a part of a consortium with a number of the animal health research institutes based throughout Scotland, and typically all together as this EPIC or Centre of Expertise on Animal Disease Outbreaks. Yeah, so thanks very much for the opportunity, and after Ken's talk, I'd be happy to take any questions. Thanks.
Great, thank you very much for that, Adam. Very fascinating talk there, and really good to hear about the work that's being done there in such an important area. So it's my pleasure now to introduce our second speaker of the day, Dr. Kenneth Barker, who is a consultant anaesthetist in NHS Highland, is also the clinical lead for the National Green Theatres programme. He's going to be telling us about the programme and about the importance of green anaesthesia in general. So Ken, I'll hand over to you if you want to share your slides and make a start, please.
Thank you. I'm hoping my slides are up there now. Robert?
Looks good, yep.
Good, thanks very much. So thank you very much to InnoScot for inviting me today. I'm going to talk about the National Green Theatres programme, or Programme National to Lawn SRUC, which is a national programme, as it says, started by the Scottish Government as part of their climate emergency strategy document from August 2022. This programme formally launched just in March of this past year, although it's really the culmination of about 6 years of grassroots work. And the aim of the programme, just going to advance my slides. Yeah, the aim of the programme really is to amass evidence and identify opportunities to reduce healthcare's burden on the planet. So that might be reducing direct emissions of carbon dioxide through better use of fuel or energy, transport, etc., either directly or through the wider supply chain. Or it might be by changing the single-use culture, maybe to more circular models so we don't have so much plastics, and of course pharmaceuticals entering the biosphere. So all of these actions as well can reduce the reutilization of virgin materials. But the key outcome of this programme is really not necessarily the details of all the actions, but the principle of embedding sustainability into every clinical decision and every managerial decision in the NHS. Some of our actions are just common sense or returning to past practices, but many do need innovation, new ideas, processes, maybe equipment. And the opportunities for innovators are here and now. The numbers at the bottom there relate to these opportunities. The 2.6 billion is the national procurement spend in Scotland every year. The 12 million is the fund at national the Medicines Device Manufacturing Centre at Heriot-Watt University have a fund of 12 million for developing new Scottish-based innovations in medical technology. And more recently, 4.62 million was awarded to a collaboration called Design Hopes, which is a collaboration between University of Strathclyde and 3 other universities, NHS Scotland, Scottish Government, and they're taking a very much a design-based approach to new technologies and designs. So again, why are we doing this? This is my local patch of snow, the permanent snow up in the Cairngorms, known as the Sphinx. It's been there and monitored for, I believe, about 300 years. I'm told it's only melted 10 times in the last 300 years, but unfortunately, 5 of those 10 times were in the last 6 years. So in Inverness, we started to develop what we call the Green Theatre project about 2019, maybe 18. We started with anaesthetic gases, which were an obvious source of pollution. We looked at surgical fluid disposal, at patient warming devices, and at energy use within the theatres, as well as waste segregation and simple things like banning of single-use items. Our theatres, for instance, used 78,000 plastic cups every year in one use and thrown away. We've now banned those and we're all using normal cups. That was the infographic. We started to speak to our colleagues around the country and formed basically what was a WhatsApp group initially. Green Anaesthesia Scotland was our name. And a group of enthusiasts. We started to talk to each other and give each other ideas, advised what pitfalls to avoid, etc. There's a photo there of us with a stand at COP26 in Glasgow, and we were back again in the same venue this year for the European Congress Declaration on Sustainability. And as you can see from the names up there, this sort of grassroots network has been copied in many other areas around the UK in anaesthesia, but also into general practice, emergency medicine, endoscopy, that side of things. And what does it mean? Well, it's taking an idea and spreading it. That's what it's all about. This slide here represents the effect of grassroots change being translated into national policy, and it shows about 8,000 tonnes of carbon dioxide equivalent savings as a result of abandoning one anaesthetic gas and replacing it with another one. That's with no detriment to patient safety or outcomes. It's just one gas replacing another. And what I like to say about this graph is it also demonstrates 2 other things. First, that this was an entirely grassroots action that can make this significant change. The government got involved, as I say, in about 2022, but this was clinicians actually taking direct action themselves. The other thing is that this represents a small spark, which has now led to this whole programme of change, which is reflected in the UK and Ireland, and in fact further afield now. This is another anaesthetic gas. Anaesthesia used to use a drug called nitrous oxide. It's a significant long-lived climate pollutant lasting around 110 years in the atmosphere with a global warming potential of 300. That's 300 times carbon dioxide. And it depletes ozone. So there's a great deal of work looking to combat its use within medicine. But thanks to work in NHS Lothian, we actually identified that due to system leaks, poor security and stock management and design, NHS hospitals actually were wasting about 80 to 95% of all the purchased NO2. So it just didn't reach the patients. So we've got a number of kind of lean processes looking at improving that. But one of the things we've done in anaesthesia is we've really just stopped using it. It's used very minimally for some pediatric indications in obstetrics, but otherwise we've abandoned its use. And work is ongoing to deal with the system losses. So in August 2022, as I say, the climate emergency strategy was released by the Scottish Government, and the National Green Theatres programme was formally adopted into that. We've got 50 or so actions. They're based around the key themes here: structural, mainly to do with engineering and energy, systems and equipment, that's the sort of things we use in theatres, including drugs and medicines. And of course, clinical practices, which are just the habits, the things that we have done for years that we need to question. And I do have a list of these 50, but I'm going to, rather than going through 50 actions, I'm going to just stand you in a theatre, which is really what we did. We stood in a theatre and looked around us and said to each other, what can we do better in this theatre from an environmental standpoint? I'll give you some examples. The red arrow and cross represent a thing called rubbing, not scrubbing. Surgical scrubbing traditionally has 22 litres or so of water, hot water on average, going down the sink for every scrub. And there's maybe 3 to 6 people scrubbing for every operation. And we're replacing that with an alcohol gel wipe, which is just as efficacious. And not only does it reduce the carbon embedded within hot water production and provision, but there's potential to actually remove scrub sinks from theatre in new designs. And we know that scrub sinks are a source of biofilms and bacterial colonisation. We're looking at waste segregation, not just to save money, but also to recoup valuable plastics and metals as well. And single-use textiles are a key area. There's about 88,000 tonnes of single-use textiles wasted and sent to incineration or landfill in the UK every year. So we're now looking at reusable options, which is, again, as I say, a kind of a return to what we used to do. Another look at the sort of things that we provide through tradition in theatres are the sort of structural things, such as the HVAC system, heating and ventilation, air conditioning. That tends to be left on or simply set back to 50% 24/7. And the guidance has been in place since 2016 that suggests that this can actually just be switched off overnight. It doesn't have infection prevention implications. And as long as there's safety mechanisms for keeping the correct humidity and temperature, that can be set back and save around 70% of the energy costs in that system. And that's one of the biggest users in the hospital. About 40% of a hospital's energy use is just in theatre HVAC systems. Central vacuum is another thing that stays on 24/7. We plug into the wall and expect vacuum to be there. But in fact, we can now look at looking at local units, because the use of surgical vacuum is intermittent and specific. We don't need it all the time, and we don't need it everywhere. And another system called anaesthetic gas scavenging, that's to remove some of our gases so they don't cause a health and safety issue for staff. What we've realised, of course, is that with new systems, we're using minimal amounts compared to when these regulations were imposed in the 80s. We also have these exceedingly efficient ventilation systems, so actually we don't think there's an issue with staff safety, and we may not need these HVAC AGSS systems at all. But of course, when we look at systems and equipment alongside pharmaceuticals, one of the great black holes that we have to deal with is the procurement side of things. And NHS procurement, as you know, is 2.6 billion. With about 60% of the spend. And one of the problems with it is that we don't ask enough questions about the carbon footprint of our products that we buy. We know that this information is often available. It's provided to a number of other European markets, but we don't ask. And I feel that we should be using that massive buying power of procurement in NHS to actually drive the market, shape the market, and ask these questions right at the outset. We should perhaps move towards Norway's model. They have a pharmaceutical contract model where 30% of the procurement weighting is for environment. So a little bit about the sort of barriers we're coming up against in this programme. Clinical autonomy, of course, is something that is relevant. Nobody likes to be told what to do, so we need to educate our colleagues and bring them with us when we're suggesting a change to their normal practice. Silo working is I'm sure the case in all big organisations. One example is we asked for our nitrous oxide manifolds to be switched off on a certain date, and about 6 months later discovered they were still switched on because we couldn't get our estates department to agree with our pharmacy department to agree with us that we didn't actually require it anymore. And then if you do want to change something, who's actually in charge? One of the systems is a thing called 7-bar air, so high pressure 7-bar air is provided usually to, or used to be, to provide power for orthopedic tools. But they've all switched over now to battery-powered, reusable battery-powered systems. So we've got this system that runs 24/7 and it's only used for 4 minutes a day. So is there a role here now for providing local cylinder high pressure air for that limited use and de-engineering the massive plant at the back of the hospital, which runs 24/7, as I say. So these clinical changes need to be communicated to the engineering side, and once they are communicated, the managerial responsibility for taking the decisions to downgrade these things has to be applied. And finance. Now, finance is often held out as a risk, but there's also an opportunity here, because one of the key things we've noticed in the 50 or so actions we have is that the vast majority of them are actually cost saving for hospitals in the NHS. This is one of the obvious ones, HVAC systems. We spend about £18 million on them. And if we did switch them off overnight and at weekends, there's a potential £10 million green dividend, as we like to call it. We're hopeful of retaining some of that green dividend to put into further development of actions. I'm not holding out huge hope for all that money, but we're hoping. And of course, risk is something that as clinicians we are quite used to. We balance risk of surgery against the benefits of the surgery almost every day with our patients, but health systems are not necessarily used to taking on risk. And this diagram here is an example. This is Pure Water International, a local company from the Black Isle in Inverness in the Highlands, and it's got a £1.8 million contract to provide a laundry water system that will clean the wastewater of microplastics and pharmaceuticals. And it also recoups heat and water to the tune of about 55 grand a year. All sounds good, but this is untested technology in healthcare. It's been utilised in the food industry, particularly in water scarce environments, but we don't yet know. We haven't proven that it's going to be a benefit to the biosphere in the Highlands. So it's good that the government, for instance, are prepared to put in that money to test these systems, because we have to examine every aspect of what we do, every mitigation we can make, because we are in a climate emergency. And we're also tapping into the very active biotech industry and the university research departments around Scotland. We need to address key areas, and we'll give you a couple of examples. Tiny Air, company from Dumfries and Galloway, they've got a prototype machine for the pre-cleaning and washing of surgical instruments before decontamination. That shows, because it's using cold water, no detergent, it shows an 80% carbon saving. And in fact, it also increases efficiency within the sterilisation units. Novus Designs, or IF, I think they've changed their name to now, they are looking at providing sterile water locally. The current practice in most of the NHS is to provide plastic bottled water that we actually ship from Norfolk, one of the driest parts in the UK, all the way to places like Fort William, the wettest part, I think. And other companies like Revolution Zero, not only offering solutions for the textile waste that I mentioned earlier on by offering gowns and drapes, but potentially also offering the laundry and sterilisation service that goes with that, because we do have a capacity issue in the NHS with our laundry and decontamination facilities. So just a few key pointers if you're interested in developing new ideas, new equipment, new systems for the NHS. First of all, I think we need to think about the source materials and what will be the second, third, fourth use of these materials. We're keen to look at local manufacture, maintenance and disposal. That benefits the carbon of the supply chain and, of course, the reliability and security of the supply. And ultimately, circularity is key. Business models that promote the linear economy are unlikely to be successful as new regulations come in, and new contract awards, I think, will have much more of an environmental basis, as well as their cost and the supply security. Finally, this is my workplace, Rigmore Hospital, the big brown building on the right, with my home over the Keswick Bridge on the Black Isle there. It's a nice place to live, and I like the photo, particularly because it's a metaphor for how I think healthcare has semi-ignored the climate crisis issues and our massive part in it, as we say, about 4 to 5%, mainly in the name of patient care first and not recognising the effect that the climate crisis is having and going to have on our patients. So, as you can see, it's a 70s designed, poorly insulated building, single glazed with metal framed windows, building recently, until recently, heated with heavy fuel oil. As you can see, it doesn't hold the snow. And the rest of society and communities and businesses, they're moving ahead, I think, with getting on with the challenge of climate change mitigation. And so for the sake of us at the NHS, our future patients, we need to get on with that. And the National Green Theatre programme, I think, is one part of the start of that journey. So thank you very much.
That's great. Thank you very much for that, Ken. Really excellent talk there. Particularly keen to see all the stuff that you're doing on the innovation theme and the companies you're working with, and the link with Heriot MDMC there as well, which is fantastic, of course. Okay, thank you both to Adam and to Ken there. We've got some time for some questions now. So we've had one or two come in, so I will just read them off the screen. So I think this question is for both Adam and Ken, actually, so I'm interested to get both of your thoughts on this one. What do you think are the easiest wins on the way to achieving NHS Scotland's net zero target in 2040, and what are the hardest? So what are the easiest wins and what are the hardest? Ken, we'll start with you, please.
I mean, this is difficult to say. I'm not going to start with the easiest one. I'm going to start with the obvious thing that we have to do in order to gain these easiest wins, and that's to deal with getting information, getting data. I alluded to the fact that we have a black hole in procurement, and that's across equipment and drugs. We don't ask the questions of our suppliers, and if we don't have the information at the beginning of things, how do we as clinicians or as procurement managers within hospitals, how do we choose between two products that are similarly efficacious? We can't, it's very difficult to make that judgment. So first of all, we need the data, and I think that is now progressing. We're working towards getting a environmental weighting that is going to give us the sort of answers we're looking for from industry. Once we've done that, then we look and see what the obvious outliers are. There are some that were obvious from the start when we got started in this journey, like the anaesthetic gases, nitrous oxide, and there are programs in place for that. I personally feel the next major things are the potential energy wastage that we have within the NHS and what we can do to address that. And that's obviously direct carbon dioxide emissions. Adam?
Hey, Adam?
Yeah. Hopefully my internet's working now. I had a short power cut here. Apologies for that. I think what would be the approach I would take would be a mapping of where things stand in terms of current environmental footprint and pinch points, similar to what Ken did, looking at that examination of the operating theatre itself. And sort of once you've mapped that pathway, then that will help identify where there might be quicker wins, where it's a sort of process change, and then the more complicated ones, which certainly would be in scope, but things like changing the material used for making inhalers, which is a massive problem, but actually quite a complicated one to steer that ship in the right direction, because there's so much supply chain and process involved in doing that. Whereas if you can turn the lights off or not run the tap for as long as Ken was talking about. I think there's quicker wins there, and very similar to the holistic approach I was talking about in ours. Once you've done that, I think looking at a holistics consideration of it as to when you pull on that one thread of if you're trying to reduce energy and carbon footprint, what other impacts might that have on the wider service provision? So if you stop driving your cars around, that's great because you're using less mileage, but what effect is that having on the service delivery or the sort of community engagement? And so I think the holistic approach is an important piece to making a decision in terms of energy reduction.
Great, thank you very much for that. Next question then is, obviously one of the consequences of climate change is that we're now starting to see the spread and re-emergence of certain diseases that had been eradicated from certain areas before, particularly things like parasitic diseases, such as malaria. How can we begin to combat things like that? We go to Adam first for this one.
Yeah, I think it's quite a significant one. So it's re-emergence of existing and then new things. So in aquaculture, I don't know how many people are aware, but there's been an emergence of major issues in the aquaculture industry. So sea lice and micro jellyfish is the current big issue there. That's both are due to changing sea temperatures, so a direct effect of climate change. So how you begin to do it, I think again it's multifaceted. In one way, it's starting to rescreen and keep an eye on where these emergent diseases are, and generating new vaccination plans, possibly coming back in combination with those screening strategies, and then possibly the non-clinical infrastructure bits, mosquito netting, things like that, in areas you never would have imagined needing them before. Malaria is an interesting one. I think had malaria been in a kind of higher GDP countries, we probably would have moved faster on it than it has in the past, just given where it's been. So maybe that's a good thing for some of those diseases that have been affecting people not like us, to be blunt, for years. Maybe there's a silver lining in that finally will accelerate development of mitigations for things like that. But yeah, it's certainly something to look at and manage.
Ken.
Yeah, we're learning a great deal from talking to each other as well. I think that one of the key programs in the north here has been the One Health Breakthrough Partnership, which is a collaboration between NHS, academia, and Scottish Water and SEPA and so forth. And so as major producers of microplastic waste and also discharge of pharmaceuticals into the environment, I think we are very conscious that what we do is affecting the biosphere in our immediate vicinity, but also in the wider sea and marine environment. So this sort of research that I suppose in the past have been worked on in particular areas. We were talking about silo working earlier on. We're beginning to recognise the beneficial effects of working together on these things. So that in itself helps us as an organisation. When I speak to infection control people and waste managers and point out that microplastics, for instance, have a potential implication in terms of antimicrobial resistance coming back to them, then their ears start to pick up a little more.
Okay, thank you. I've got time for one last kind of quick question here, which is coming from Vivian McKinnon. Does the NHS have an environmental accreditation scheme which sites and boards can work towards? I guess Ken probably first, and then maybe Adam after that.
I need to probably get my Director of Climate Change delivery here. What we are doing as a National Green Theatre programme is we're providing the information and the role models, the case series to ask our health boards to comply with the actions that we've suggested, and we give them assistance if they require that. They are now being asked to put that into their annual development plan, or annual delivery plan, I should call it, which they have to report back to Scottish Government. So although there isn't, as far as I know, an accreditation scheme, what there is now, which is one of the advantages of the Scottish scheme, is that there is now an obligation on chief execs within health boards to either comply with exactly the things that we're suggesting as actions, or to give a reason why they have a better option or a better solution. And because they have to report that back in their annual delivery plan, then it becomes something that will be seen in every theatre, in every Scottish hospital. Ultimately, that's the plan. Rather than accrediting each theatre, we're expecting the chief execs to actually comply with that. Does that make sense?
Thank you. Adam, anything you want to add?
Yeah, well, since I'm not in the NHS, I'm not sure if I can answer directly, but from an agriculture perspective, that is something that Scottish Government at least is doing from livestock and agriculture generally, is looking at measurements of energy consumption and carbon footprinting, and looking at that from a subsidy level as well. So a bit of a carrot as well as a stick on that side. And I think farming is moving in that direction. It'd be interesting to see if the NHS takes up something similar in the future, where it's maybe there's a carrot associated with the adoption of more green approaches. I think livestock, we're sort of consumer driven as well, which is maybe a bit different than the NHS. And we're starting, although it's early days, to see a demand for how much sort of environmental impact is that steak that you're buying in Sainsbury's or Tesco or wherever. I wonder if there's an equivalent there in the NHS as well for visibility to the patients, which I think could also drive things if they know, what I'm asking for as a patient, either as needs or requests, what that does for the NHS.
Yeah, I'll just come back on that briefly and just say, yeah, that fits very much with what a kind of policy thing in the NHS called realistic medicine, where we're trying to involve the patient in these decisions. And in fact, environmental consequences of their treatment is part of that informing process.
Great, thank you for those answers. Well, unfortunately, that's the end of our time now. Just remains for me to say a huge thank you to both of our speakers today for two fascinating talks. I've certainly learned a great deal, and I'm sure you as the audience have as well. One more thing to say is that this is the last of our webinars for 2023. We'll be back in 2024 with a full programme, and we'll be kicking off in January with confirmed speakers, Richard Lockhead, MSP, who is the Minister for Small Business, Innovation, Tourism and Trade, and he'll be joined by Carrie Thompson, who's the Programme Lead for Innovation Collaboration at the Chief Scientist's Office. So you can expect a very government, political themed webinar to kick off the new year. But thanks to all of you, thanks to our speakers again, thanks to all of you for joining today. I hope you found this enjoyable and useful, and do enjoy the rest of your day. Thank you.